Welcome back to the deep dive. Our mission here, as always, is to give you that essential, critical knowledge you need without you having to read all the dense source material yourself. Today, we are taking on, well, a truly foundational challenge for anyone who's heading into medicine. We're going to understand population health and epidemiology, anchored by Davidson's clinical textbook.
That's right. And if you're a first or second year medical student or you're getting ready for your clinical rotations, this deep dive it's absolutely crucial. We're focusing on how disease operates at a societal level. The mission today is really to solidify the key definitions, look at the global movement of disease burden, and, maybe most critically, to help you grasp the context in which your patient lives. You know, what happens before they even walk into your clinic. That is often the major determinant of their health.
Far more than the healthcare system itself.
Far more. It's a tough concept to internalize sometimes, but it's true.
Okay, so let's unpack this. We're going to cover 4 big areas. First, the essential global burden metrics, specifically something called DALYs, and what those numbers tell us about how humanity is doing. Then, the profound, kind of layered influence of socio-environmental factors, which Davidson calls the hierarchy of systems.
After that, the 2 major tools of population-level prevention, screening and immunization.
And finally, we'll get into the core epidemiological toolkit, including how cutting-edge genetics is now being used to strengthen our ability to, actually prove causality.
Exactly. This isn't just theory for an exam. This is the wide-angle lens you need to successfully practice 21st century medicine.
Okay, let's start at the very beginning. Definitions. We hear public health and population health thrown around all the time. Are they the same thing?
They're often used interchangeably, but no, the difference in scope is actually really important for understanding policy. The foundational definition of public health, this comes from the UK Faculty of Public Health, is very broad. It's defined as the science and art of promoting and protecting health and well-being, preventing ill health, and prolonging life through the organized efforts of society.
Organized efforts of society. That sounds big, like government-level stuff.
It absolutely is. That definition immediately tells you that public health demands collective action, wide-ranging partnerships.
So it's not just doctors.
Not at all. It involves everyone from government setting tax policy on tobacco, to local councils ensuring sanitation, to transport departments planning safe cycle lanes. It's the whole system.
Right. So how does that differ from population health?
Population health is a concept we, as future clinicians, interact with a bit more directly. It focuses on the health outcomes of a specific group of individuals, and this is the key part, critically including how those outcomes are distributed within the group.
So it's about equity.
Yeah.
Or the lack of it.
Precisely. Public health is the broad policy in action for everyone. Population health is looking at the measurable results and the disparities within a defined group, say, all the patients served by a particular hospital, or everyone living in one specific neighborhood.
Okay, so let me see if I've got this. If I'm seeing a patient with, say, uncontrolled high blood pressure, public health would be the national salt reduction policies. But population health would help me understand if the rate of uncontrolled hypertension is way higher in my specific patient group compared to the town next door, and why that gap exists.
That is the perfect distinction. And it shows how your role as a doctor extends to both. You're treating the individual clinically, but you also have a role in supporting those broader public health actions that are needed to fix those inequalities for your whole population. Hashtag tag 1.2, the global burden of disease, UBD exercise, and the daily metric.
Okay, but we can't address those inequalities if we can't measure them right. How does the world even begin to quantify global suffering in a way that's standardized, that's comparable from country to country?
Well, that's exactly the purpose of the Global Burden of Disease Exercise, or the GBD. It's this monumental ongoing effort that was started by the World Bank way back in 1992.
92, wow.
Yeah, and its purpose was very pragmatic. It was to move away from, patchy, unreliable data and to produce robust, consistent estimates of disease and injury burden, and to assess all the risk factors, physiological, behavioral, social, that go along with them.
So it's about creating a level playing field for data so policymakers can actually make evidence-based decisions.
Exactly. And the universal metric they developed for this is the daily. We're calling this the world standard health currency.
The health currency, I like that. So what is a daily? Break it down.
A daily is a disability-adjusted life year. And that currency metaphor is really the best way to grasp it. One daily represents one single year of healthy life that's been lost due to illness, disability, or premature death.
So it measures the total cost of a disease to a society. Not just deaths, but suffering, too.
Exactly. It combines them. So you can break the daily down into its two components. First, you have years of life lost, or YLL. This is the measure of premature mortality. It's calculated by taking the number of years a person lost relative to a standard expected life expectancy.
So if the expected lifespan is 80 and a 40-year-old dies of a heart attack, that's 40 YLL.
Simple as that.
Okay.
Now, the second component is the one that accounts for the suffering, even if the person lives a very long life. That's the years of life lived with disability, or YLD.
Right, and this must be trickier to calculate.
It is, because you can't just count the years. You have to weight them for severity.
Yeah.
So YLD is the number of years a person lives with a disability multiplied by a severity weighting factor.
A weighting factor, what does that look like?
It's a scale from 0, which is perfect health, to 1, which is equivalent to death. So a condition like, say, severe chronic depression or really bad low back pain might have a weighting of 0.3.
I see.
So if you live for 50 years with that severity of back pain, you've accumulated 15 YLDs over your lifetime.
Okay, so a young person dying suddenly in an accident is almost all YLL, but someone who lives to be 90 but has severe Alzheimer's for their last 20 years might have a huge YLD, but a very small YLL.
Exactly. And the power of the daily is that it puts them on the same scale. It forces policymakers to recognize that chronic suffering and early death are both equally valid, equally important calls on our health resources.
And to make this all work globally, they have to be really strict about how they classify things.
Incredibly strict. The GBD uses the International Classification of Disease, the ICD rules, to assign a single cause to each death. This global standardization, presented by age, sex, and region, is what gives us this robust platform for comparing apples to apples across the world. Hashtag 1.3, global trends in life expectancy and causes of death.
So now that we have the metric, this health currency, let's look at the global report card. What does the GBD actually tell us about human progress? Are we doing better?
The headline is overwhelmingly positive. Global life expectancy rose substantially from 61.7 years in 1980 to 73.2 years in 2017. That's an average increase of about 0.3 years every single year for almost 4 decades. That is a massive achievement for humanity.
That's incredible. What was the main thing that drove that gain?
The single biggest driver was the huge fall in child mortality, primarily from common infectious diseases.
Like pneumonia, diarrhea.
Exactly. We just got much, much better at preventing and treating infections in young children. But, and this is a big but, this progress was partly offset by rising mortality from adult chronic conditions.
Which ones?
Specifically diabetes and chronic kidney disease. And of course, we have to remember these gains aren't universal. Regions facing war or violence or severe epidemics often see life expectancy stagnate or even go backward.
This all leads to this fundamental shift that we hear about the global health transition, the idea that infectious diseases are receding and chronic illnesses are taking over. How stark is that shift, really?
Oh, it's the defining story of modern global health. In 1990, communicable, maternal, neonatal, and nutritional causes, they accounted for about 1/3 of all global deaths.
1/3. Okay.
By 2019, that had dropped to 1/4. In the meantime, non-communicable diseases, the NCDs, the chronic illnesses, they tightened their grip. They now account for about 2/3 of all global deaths.
2/3. That is a gigantic change in focus for health systems everywhere. Which NCDs are the biggest killers?
Well, the list is dominated by the big 4. Cardiovascular disease, so ischemic heart disease and stroke. But that leads the way. Responsible for about 18.5 million deaths a year.
Okay, number 1.
Neoplasms cancers are second at roughly 10 million. And chronic respiratory diseases add millions more. When you put those together, you can see why health systems globally are just buckling under the weight of chronic care.
Okay, but here's the paradox that I think needs explaining. If the age-standardized death rates for most diseases are falling, meaning at any given age, you're less likely to die from most things than you were in 1990. Why are the absolute numbers of deaths and the total burden on health systems rising so much?
This is such a critical insight for you to grasp as a future clinician. The strain on the system is driven by demography, not just disease. There are 2 big forces at play.
Okay.
First, just simple global population growth. There are more people, period. But second, and more importantly, the population age structure is shifting. We're seeing what's called an inverted population pyramid.
The inverted pyramid. So the base, the number of young people, is shrinking relative to the top, the number of older people.
Precisely. More people living longer means a disproportionate growth in the oldest age groups. And those are the people who naturally accumulate multiple NCDs. So even though the rate of death is lower at any given age, the sheer number of people entering those high-risk older age groups means the total volume of complex chronic illness is just surging.
It's a demographic tsunami hitting the medical system.
That's a great way to put it. And we have to remember, there are a few diseases where the trends are going in the wrong direction, even on an age-standardized basis.
Which ones are those?
Age-standardized death rates are still rising for HIV/AIDS, for diabetes mellitus, and for chronic kidney disease. And again, massive regional variation. In sub-Saharan Africa, for instance, those communicable and maternal causes still account for 2/3 of premature deaths.
So let's just anchor those top-level numbers from 2019 for everyone listening. Cardiovascular disease is number one.
Yep. The top 5 causes of global deaths in 2019 were, number 1, cardiovascular disease, 2, neoplasms or cancers, 3 was chronic respiratory diseases, 4, respiratory infections and TB, and number 5, diabetes and chronic kidney disease combined. Hashtag 1.4, disability and policy priority.
Okay, but the Daily metric reminds us that living sick is just as important as dying early. So let's flip to the YLD side of the equation. What are the top causes of global disability?
This is where the GBD exercise made a massive, massive contribution to policy. Before the GBD, high-level health policy was almost entirely focused on mortality.
Right, on what kills people.
Exactly. The GDD provided irrefutable evidence that conditions causing a huge burden of disability but very few deaths required urgent attention.
And what were some of the surprise entries on that disability list?
The top 5 causes of global disability, so YLD, in 2019 were, number 1, musculoskeletal disorders like low back and neck pain.
Wow, number 1.
Number 1. Number 2, mental disorders dominated by depression and anxiety. 3, other non-communicable diseases. 4, neurological disorders. And 5, sense organ diseases. The fact that depression and low back pain consistently top those charts it's remarkable.
It's a powerful reminder that millions of working years are lost not to these dramatic, sudden diseases, but to chronic, grinding pain and mental suffering.
And that insight really did drive a transformation in policy. The evidence from dailies meant more priority, more funding, was directed toward conditions like depression and asthma and chronic musculoskeletal problems. It shifted the focus from just extending lifespan reducing YLL to maximizing health span and functionality reducing YLD.
Okay, let's take a quick pause there. Time for a quick check. The total burden of disease is measured using the daily. Now, if we implement a fantastic public health program that significantly reduces the prevalence of chronic knee osteoarthritis across the population, which daily component are we primarily targeting? If you need a reminder of the difference between YLL and YLD, just rewind and listen again to the daily metric discussion.
And the key takeaway from this whole section is this. The world's disease pattern is firmly shifting toward NCDs and disabilities, and this is driven by demographic changes, population growth, and that inverted age pyramid. Health systems absolutely must transform their focus from episodic acute care toward continuous integrated chronic disease and disability management.
Okay, so we know what is disabling and killing people globally. Now let's look at the causes of the causes. The GBD exercise also ranks the risk factors that are driving this burden. Which exposures are doing the most damage right now?
Well, in 2019, the top 5 global risk factors were, number 1, high blood pressure. 2, smoking and secondhand smoke exposure. 3, high fasting blood glucose. 4, low birth weight. And number 5, high BMI.
And the really telling part of this is how the ranks have changed since 1990. These are not static threats. High blood pressure jumped from 7th to 1st, high fasting blood glucose from 11th to 3rd, and high BMI from 16th all the way up to 5th. I mean, these are the modern epidemics.
They are. And this data really implies a critical failure point in public health. While we've had massive success in reducing infectious disease risk factors, we are, demonstrably failing to contain the leading physiological and metabolic risks.
The report was pretty blunt about that, wasn't it?
It was. It basically said that public health efforts are not giving enough priority to these key global risk factors that are just increasing over time. We're seeing major health challenges, major financial challenges as a direct result.
And the burden isn't equally shared. The GBD found that while socio-demographic development has progressed, the gaps, the inequalities are widening fastest in the countries that are already the most developed.
It's a highly counterintuitive finding, isn't it? In the wealthiest societies, Inequality is deepening rapidly, and health outcomes are diverging. Those rising factors, high blood pressure, high glucose, high BMI, air pollution, drug and alcohol use, they all disproportionately hit the most vulnerable populations, and that creates these massive socioeconomic divides in chronic disease. Hashtag 2.2, the hierarchy of systems, from molecules to ecologies.
To really understand how we got here, we have to adopt a systems approach. For you, as a future clinician, this concept of the hierarchy of systems is arguably the most crucial concept in the chapter. It forces you to look beyond the individual organ and see the entire context. I like the metaphor of the Russian doll of health.
The Russian doll is a perfect metaphor because health is influenced by these layered systems, extending far beyond an individual's genetics or their immediate personal environment. And the critical insight here, and we need to keep repeating this, is that healthcare itself is usually not the major determinant of a population's health status. It's all those outer layers of the doll that matter most.
Okay, let's make this concrete. Let's anchor it using the specific medical example from the book. Ischemic heart disease, or IHD. Let's trace this one condition through every single layer of that doll, from the smallest to the largest.
Great idea. So we start at the very core, the innermost doll. That's the molecular level. This is the genetic or chemical starting point. For IHD, this could be, say, a specific ApoB mutation that causes familial hypercholesterolemia.
Okay, the gene.
Then the next layer out is the cellular level. The molecular event leads to cellular action. In this case, foam cells, full of cholesterol, start to accumulate in the vessel wall.
From there, we go to the tissue and organ.
Exactly, the tissue organ level. The accumulation of foam cells forms an atheroma, which leads to thrombosis or clotting of the coronary artery. This is the disease process at the macroscopic level, which you can see.
And then the person.
The system-person level. This is the clinical presentation. The heart attack causes ischemia and infarction of the myocardium, and that leads to consequences like cardiac failure, limited exercise capacity, which in turn affects the person's ability to work.
Right, and these 4 layers, molecular to person, that's generally what clinicians focus on, right? But the hierarchy of systems says we have to pull back and look at the environment.
Absolutely. The next layer out is the family community level. Here, we find the immediate environmental and social exposures, things like passive smoking from a partner, a poor diet that's driven by what's available locally, the lack of shops selling healthy food, or safe places for leisure like parks.
So the availability of a safe park versus a busy, polluted street, that's the community layer directly influencing my patient's ability to exercise after a heart attack, and the outermost layer of the doll.
This is the most distant, but in many ways the most profound layer, the population society ecology level. This includes national policies. What's the overall prevalence of obesity in society? What are the government policies on smoking cessation and screening programs? And critically, things like agriculture policies that influence the fat content in the national diet, or transport policies that favor driving over walking.
That's so powerful. But it also presents a huge challenge for a clinician, doesn't it? I mean, if farming policy is that influential, how do we as doctors focusing on one patient ethically balance treating the sick tree versus advocating for the health of the entire forest?
That is the core conflict. And recognizing this hierarchy, it fundamentally changes your approach to taking a history. You have to go beyond just asking, do you smoke, to asking, do you live in a safe neighborhood where you can easily get healthy food? Your role shifts from just prescribing a statin for hypercholesterolemia, which is the cellular level, to potentially advocating for better urban design or school nutrition standards, which is the society level. Hashtag 2.3, the life course perspective.
So the hierarchy of systems is about all these layers of influence happening at the same time. But now we have to add the dimension of time. Health isn't just determined by factors at one single moment. It's the result of cumulative experiences across a whole lifetime. This is the life course perspective.
That's right. The life course perspective tells us that exposures to illness, to adverse environments, to harmful behaviors, they accumulate, starting from conception.
It starts that early.
It does. And what's particularly fascinating is the concept of pre-birth programming. The shadow starts even before the first breath. It's a mechanism that's thought to permanently alter the body's physiological settings. Low birth weight, which is often linked to undernutrition during the middle to late part of gestation, is believed to permanently program a person's cardiovascular and metabolic responses.
What do you mean by program?
Well, the idea is that the fetus anticipates a resource-scarce environment outside the womb, and so it sets its metabolism to be very efficient to hold on to every calorie. This is sometimes called the thrifty phenotype.
And what are the long-term consequences of that thrifty programming when the person is born into a world with plentiful food?
It leads to a permanently higher risk of hypertension, of dyslipidemia, and of type 2 diabetes in young adulthood. And that, in turn, dramatically increases the risk of cardiovascular disease in middle age. This linkage means the nutritional status of a mother can directly impact her child's chronic disease risk decades and decades later.
Which makes the implication for prevention crystal clear. You can't just wait until someone is 50 to start counseling them about diet and exercise.
Absolutely not. Successful prevention requires intervention very early in life or even pre-birth across multiple levels of that hierarchy of systems. Prevention isn't a single intervention. It's a continuous, multi-layered process that has to address the socioeconomic factors influencing maternal health and early childhood development. Hashtag 2.4 case studies and global risk factors.
Okay, let's drill down now on a few of those major risk factors we identified: alcohol, smoking, obesity, and the environment, and see how these principles of hierarchy and life course actually play out in the real world. Let's start with alcohol, which is an increasingly important risk factor globally.
It is. Alcohol consumption and the related harms are rising significantly, and the source material attributes this rise mainly to market forces: falling real prices of alcohol, increased availability, and cultural shifts toward higher consumption.
So the interventions so far haven't really worked.
The evidence suggests that things like voluntary agreements with industry or minor licensing restrictions have often proven insufficient. So we need to shift the intervention to the societal level.
What would that look like?
It means more aggressive public health measures are required. Things like a minimum price per unit of alcohol, significantly tightening licensing laws, and seriously curtailing promotion and advertising. The clinical impact of not doing this is clear: rising liver disease, violence, accidents, and mental health issues.
Okay, next, smoking. It's still stubbornly in the top 3 global risk factors, even though rates are declining in many high-income countries.
And the clinical consequences are just vast. It's so much more than lung cancer and COPD. It contributes to multiple other cancers. It dramatically increases the risk of peripheral vascular disease, stroke, peptic ulcers. And maternal smoking causes fetal growth retardation, which reinforces that life course perspective we just talked about.
Let's use smoking to illustrate that hierarchy in action again. It's such a complex problem.
It is. So at the molecular and cellular level, you have nicotine causing physical dependence. But that dependence is then reinforced by these powerful socio-environmental drivers. On one hand, you have the personal desire to quit. On the other, you have a vast, well-funded tobacco advertising budget designed to encourage use.
Which far outstrips the resources for cessation programs.
By orders of magnitude. So the successful strategy has to hit all the levels.
Yeah.
Economic with taxation, social with public place bans, and personal with cost-effective cessation support like nicotine replacement and behavioral counseling.
Okay, now to the factor that's had the most dramatic rise in the global ranks: obesity. The idea that this is just a failure of individual willpower is clearly wrong.
It is completely wrong, and the data proves it. We are seeing the weight distribution of almost the entire population shifting upwards. For example, the average UK adult gaining about 1 kilogram per year. This cannot be explained by millions of people suddenly losing their willpower all at once. It's a problem of the obesogenic environment.
The obesogenic environment, how exactly does that work?
It's an environment that has been designed by societal factors, by policy, by agriculture, by industry, that encourages us to consume excessive energy and expend minimal energy.
Give me some examples.
Think about the cheap, heavily marketed, energy-rich foods that dominate supermarket aisles. Think about the increase in labor-saving devices in our homes and workplaces, the loss of safe walking routes, our dependence on cars and public transport. The environment makes a healthy choice the difficult choice.
So treating the epidemic requires a strategy that tackles both the individual and the ecosystem they live in.
Exactly. We must help individuals who are already obese, but crucially, we need population strategies to fundamentally reverse that obesogenic environment. And that means policy interventions related to food subsidies, urban planning, and regulating the marketing of high-fat, high-sugar foods, especially to children.
Let's touch on the poverty and affluence dynamic. This idea of the double burden is a serious challenge for many countries.
It is. Historically, poverty meant infectious diseases and malnutrition. Affluence meant chronic conditions like heart disease. But now, many developing countries are suffering from the double burden. They have large populations still grappling with poverty-related issues right alongside growing, affluent, urban populations who are suffering from chronic NCDs.
And even affluence itself brings its own health costs.
It does. Sustained economic growth hasn't solved the litany of socioeconomic problems in high-income countries. We see rising crime, environmental congestion, persistent inequality, and major mental health problems, all consequences of highly developed but potentially unsustainable lifestyles.
And finally, let's wrap this section with the big environmental determinants, starting with atmospheric pollution.
This is a major immediate health threat, particularly in big cities all over the world. Emissions from industry and vehicles, sulfur and nitrogen oxides, tiny respirable particles, metals, they severely pollute the air. And this significantly increases death rates from respiratory and cardiovascular disease, especially in vulnerable adults.
And in low-income countries, there's the problem of indoor pollution.
Yes, it's a terrible problem. Indoor pollution from heating and cooking combustion leads to tragically high rates of respiratory disease, especially in women and children.
And then there's the biggest environmental threat of all, climate change and global warming.
The source material argues this is the most important environmental health issue of our time, and it's driven primarily by human activity. The health impacts are cascading. We are already seeing millions of lives lost to drought and floods, massive economic costs, and crucially for medicine, changes in the geographical range of vector-borne infectious diseases.
So we're seeing things like malaria and dengue spreading to places they've never been before.
Exactly. And the challenge seems almost insurmountable from a clinical perspective because the cause is so far removed from the clinic. For the health sector, this means we have to focus not just on treating the victims of extreme weather events, but also on proactive adaptation like better surveillance for new diseases and mitigation like promoting sustainable low-carbon transport.
Okay, another point for reflection. Quick check. Give an example of how one factor at the societal ecological level, that's the outermost ring of the Russian doll, influences ischemic heart disease risk at the organ level, the level of the heart itself. If you struggle to make that connection across the layers, just rewind and review that IHD example.
And the key takeaway for this section: health interventions have to be layered across the life course and across multiple systems. Your clinical intervention is necessary, of course, but the population's health trajectory is most often determined by policy, by the environment, and by social equity, all the domains that exist outside your clinic walls.
Okay, prevention is the ultimate goal in population health. Let's move to the two major population-level interventions: screening and vaccination. Let's start with screening detecting disease before symptoms even appear.
Right. So screening is defined as applying a test to a large number of asymptomatic people. And the sole purpose is to reduce morbidity or mortality from a disease.
It sounds simple, but it's actually one of the most complex things to get right in public health, isn't it?
It really is, because you are intervening in people who believe they are healthy. And that's why we rely on these very strict criteria. We need to introduce the 4 gatekeepers, the Wilson and Younger criteria, which any proposed screening program absolutely has to satisfy.
The 4 gatekeepers. Okay, what are they?
First, is the disease an important public health problem? It has to be common, cause significant disability or death, have a major societal impact.
Gate number 1.
Second, is there a suitable screening test available? The test itself has to be cheap, acceptable to people, easy to perform, safe, and crucially, it has to give a valid result. So high sensitivity and high specificity.
Okay, what's gate number 3?
Is there a recognizable latent or early stage? If the disease progresses from healthy to deadly too quickly, screening is useless. You need a detectable preclinical phase where you can intervene.
In the 4th and final gate.
Is there effective treatment for the disease at this early stage, which actually improves prognosis? This one is essential. If finding the disease early just moves the diagnosis forward but doesn't offer a better outcome, then the screening has failed. It just gives people more time knowing they have an untreatable condition.
Right. It's just early diagnosis of a death sentence, which is of no benefit.
Exactly. And even when a program seems to meet all these criteria, it has to be rigorously evaluated in robust, randomized, controlled trials. And this leads us directly to the methodological traps we have to avoid when we're interpreting the results of those trials, the infamous biases.
We have to be really clear on these. There are 3 big ones that can make a screening program look much better than it actually is.
The first is self-selection bias. This happens because the people who volunteer for screening are often those who are already more health conscious. They eat better, they exercise more, they adhere to medical advice. They inherently have better health outcomes anyway.
So the benefit you think is from the screening test is actually just because you've picked a healthier group of people to start with?
That's it. The second one is maybe the trickiest for students. Lead time bias.
Okay, break this one down.
Lead time bias makes survival time appear longer, even if it isn't. Imagine a disease where treatment doesn't change the time of death. Let's say it's age 75. If we diagnose it at age 73 because of symptoms, survival is 2 years.
Okay.
But we screen at age 65 and detect it early, survival now looks like 10 years.
Yeah.
But the person still died at 75. The screening just gave the patient 8 extra years of knowing they had the disease, but no extra years of life.
It just starts the clock ticking earlier, but the finish line is in the same place. And the third bias.
That's length bias. Cancers and other diseases grow at different rates. The slower-growing, less aggressive forms of a disease stay in that detectable preclinical phase for a longer period of time.
So they're an easier target for the screening test to find.
Exactly. So screening tests are statistically more likely to detect these slow-moving, less lethal cancers than the fast, aggressive ones. So when you analyze the outcomes, the screen group inherently looks like it had a better prognosis, simply because you captured the cases that were less likely to kill them anyway.
And beyond these biases, what are the genuine harms of screening that we have to balance against the benefits?
The harms are significant. The main concern is overdiagnosis. This is when you detect a disease, often a slow-moving cancer or an abnormality, that would never have progressed to cause the patient harm or death in their lifetime.
And treating those cases is pure harm.
It's unnecessary surgery, radiation, financial cost, and severe anxiety. We also worry about false positives leading to invasive, stressful follow-up tests and false negatives giving people false reassurance.
So let's ground this in the real world. What are the key UK screening programs our listeners should know about?
Well, the UK runs major national screening programs for cervical, breast, and colorectal cancer in specific age groups. But the timeline of pregnancy and newborn screening is equally comprehensive. We screen pregnant women for fetal anomalies and infectious diseases. After birth, there's the physical exam, the newborn hearing screen, and maybe most vitally, the newborn blood spot screen.
That blood spot screen is such a powerful example of early intervention. What does it test for?
It tests for critical conditions where getting in early prevents severe, lifelong disability. This includes sickle cell disease, cystic fibrosis, congenital hypothyroidism, and inherited metabolic disorders like PKU. It's a program that passes all 4 of those Wilson and Youngner criteria with flying colors. #tag 3.2 principles of immunization.
Okay, so from detection to active protection, immunization. It's achieved results that are just, well, unparalleled in population health history.
It is the single most powerful tool for infectious disease control, without a doubt. We first distinguish between the 2 types of immunity. Passive immunity is short-term protection. It's achieved by injecting ready-made antibodies like the monoclonal antibody palivizumab, which is used against RSV in premature infants.
And the long-term goal is always active immunity.
Right. Active immunity is what you get from a vaccine. It stimulates the person's own immune system to generate antibodies and cell-mediated immunity for both short and longer-term protection.
And the effects of a vaccination program extend far beyond just protecting the person who got the shot.
Oh, absolutely. There are 3 crucial indirect effects. Firstly, eradication. Vaccination was used to completely eliminate smallpox from the planet, and polio eradication is the current target.
Okay.
Secondly, herd immunity. This is the protection of non-vaccinated individuals in the population, simply by reducing the overall rate of transmission. If enough people are vaccinated, the pathogen can't find a susceptible host to jump to, and that protects people who can't get the vaccine, like infants or the immunocompromised.
And the third indirect effect, which links back to modern challenges, reducing antibiotic resistance.
This is a major public health win. By vaccinating against bacteria like Streptococcus pneumonia, we selectively reduce the prevalence of the serogroups that were historically associated with antibiotic resistance. Fewer infections mean less antibiotic use, and that slows down the evolution and spread of resistant bugs in the community.
All right, let's make sure that complex bias discussion has sunk in. Quick check. Which of the 3 screening biases leads to the conclusion that screened individuals live longer, even if their actual date of death remains completely unchanged? If you're drawing a blank, just rewind and listen again to the section on screening biases.
And the key takeaway here: screening is a powerful tool, but it requires extreme rigor. It has to meet those strict criteria and be constantly evaluated against known biases and the critical risk of overdiagnosis. Immunization, through its direct and indirect effects, remains humanity's most effective tool for controlling infectious disease at a population level.
Okay, epidemiology. This is the detective work of population health. It's how we quantify disease, track its spread, and test our assumptions about cause and effect. Let's establish the language, starting with the 2 core measures of disease frequency. prevalence and incidence.
Right. So prevalence is the simpler of the two. It's a snapshot in time. It's the ratio of the number of people with a longer-term disease at a specific moment relative to the population at risk.
So like saying 10% of people over 80 have diabetes?
Exactly. It tells you about the current burden of the disease on the health system. It's a head count of existing cases.
Whereas incidence is about the speed at which new cases are occurring. It's about the movement from healthy to diseased.
Precisely. Incidence is the number of new events occurring in the population at risk during a defined period of time, and it's almost always expressed as a rate. This brings us to the most confusing element for new students, the denominator, which is person time.
Let's spend a minute on person time. This is often the concept that trips people up because it's not a simple head count.
It's not. Person time is essential for calculating a true incidence rate because populations are dynamic. People die, they move away, or, crucially, they develop the disease and are no longer at risk. The denominator has to represent the total accumulated time the population was actually at risk.
Okay, give us a simple anchor example.
Let's say we're tracking 1,000 new medical students to see how many develop an anxiety disorder over their first year. If 100 new cases occur, we can't just say the population at risk was the 1,000 for the whole year.
Because the 100 students who developed it weren't at risk of getting it for the first time anymore.
Exactly. So for simplicity, we generally assume they developed the condition halfway through the year. Therefore, their contribution to the total exposure time is only 50 person years. That's 100 people times half a year.
I see.
So the denominator for the incidence rate is the total 1,000 person years minus those 50 person years, which gives us 950 person years. The incidence rate is 100 new cases per 950 person years of observation.
Okay. Now, contrast that complex rate with the simpler measure, cumulative incidence, which is also called risk.
Right. Risk is simpler because it's a proportion, not a rate. It's just the number of new cases as a proportion of the total number of people who are at risk at the beginning of the study.
So in our med student example, it would just be 100 divided by 1,000, or 10%.
Exactly. A 10% one-year risk.
Yeah.
The key is you always have to define the time period. And these measures, prevalence, incidence, risk, they form the basis of what we call descriptive epidemiology. We use them to describe disease variation according to time, person, and place, and that description is what generates the hypotheses that analytic epidemiology then tries to prove. Hashtag 4.2 study designs and the challenge of causality.
Okay, so descriptive epi identifies associations. Analytic epi tries to determine causality. Why is establishing cause and effect so much harder for epidemiologists than for, say, a lab scientist?
The challenge is inherent in what we study, disease in free-living humans.
Yeah.
We can't ethically or practically manipulate conditions. We can't randomly assign 500 people to smoke 3 packs a day for 20 years to see what happens.
Right.
This inability to directly manipulate conditions is why we have to rely on sophisticated observation to try and differentiate a true cause from a non-causal association.
Let's review the toolkit of study designs they use to do that, starting with the gold standard, the clinical trial.
The clinical trial is the closest we can get to a true lab experiment. You randomly allocate patients to an intervention or a placebo, and you compare the outcomes. The random allocation is supposed to distribute all the other factors, the known and unknown confounders, equally between the groups.
But trials are incredibly expensive, and sometimes they're just not possible. So we have to rely on observational designs, which are much more vulnerable to all these problems.
Right. We rely on 3 main observational designs. The cohort study is where you enroll a sample of people, you track them forward in time, and you compare outcomes based on their observed exposures. The famous Framingham Heart Study is the classic example that identified the risk factors for cardiovascular disease.
But they take decades and cost a fortune, so there's a faster, cheaper option.
The case control study. This works backward. You find your cases, people who already have the disease, like lung cancer, and you find matched controls without the disease. Then you compare their past exposures, like their smoking history, between the 2 groups. Dahl and Hill's study on smoking and lung cancer was a case control study. It was quick and efficient, but it's highly vulnerable to recall bias.
Meaning the people with cancer might remember their smoking history differently than the healthy controls.
Exactly. And finally, you have the quick snapshot design, the cross-sectional study. This is where you just enroll a snapshot of people and get data on their exposures and their outcomes at the same time. This is great for measuring prevalence, but because you measure everything at once, you can't determine the temporal sequence. Did the exposure cause the outcome, or did the outcome lead to the exposure?
And the biggest enemy of all these observational studies is the third rail of epidemiology, confounding.
Confounding is where the relationship you see between an exposure and an outcome is distorted or confused by the presence of a third factor that you haven't measured or controlled for.
I like the metaphor of the hidden puppet master.
That's a great metaphor. It's the factor that's secretly pulling the strings on both the exposure, say coffee drinking, and the outcome, lung cancer, making the coffee look guilty when it isn't the true cause.
Let's use that classic example to really drill this home.
Okay, so we observe an association. People who drink a lot of coffee seem to have higher rates of lung cancer. If we stop there, we conclude coffee is the problem, but we look for the hidden puppet master and we find it. Smoking.
Right.
Smoking is a known true cause of lung cancer, and people who smoke are also statistically more likely to drink a lot of coffee. So smoking is confounding the coffee-gall cancer association. If we analyze the data while properly adjusting for smoking status, the association between coffee and cancer just disappears. And that balancing act, using good design and statistics to minimize chance, bias, and confounding, that is the core challenge of epidemiology. #tag 4.3 Mendelian randomization, MR Matrix trial.
Okay, so since randomized trials are often impossible and observational studies are plagued by confounding, epidemiologists have turned to genetics to strengthen their causal inferences. And Mendelian randomization, or MR, is this brilliant way to try and bypass all that confounding noise.
It is. MR is designed specifically to test if a relationship between a modifiable risk factor, like high LDL cholesterol or high BMI, and a disease is truly causal. It tries to provide evidence that's similar to a randomized controlled trial, but without the ethical or logistical problems.
How does it manage to randomize anything when it's still using observational data?
It uses genetic variation as its instrument. We identify specific genetic alleles that naturally influence the level of the risk factor we're interested in, like a gene variant that causes slightly higher lifelong LDL cholesterol.
So it's using genetics as a proxy for the risk factor.
Exactly. And we can think of MR as relying on nature's randomizer. Because your genetic alleles are allocated randomly at conception, according to Mendel's laws, the inheritance of that genetic variant is essentially a natural, lifelong, and most importantly, randomized assignment.
That randomization at conception is the key. It means the genetic instrument shouldn't be associated with all the socioeconomic or lifestyle factors that usually confound our observational studies later in life.
Precisely. The genetic variant is assumed to be associated only with the exposure, the risk factor, and not with the confounders. We then investigate the lifelong effect of those genetically determined differences in the risk factor on the disease outcome. Now, because the effect of a single genetic variant is often tiny, MR requires massive data sets, which is why it relies on resources like the UK Biobank and data from genome-wide association studies.
But it's not a perfect system. What is the single biggest challenge in interpreting Mendelian randomization results?
The most significant challenge is a concept called pleiotropy. Pleiotropy is when a genetic variant, besides influencing the risk factor you're interested in, like LDL cholesterol, also influences the disease outcome through an entirely different biological pathway, or maybe even by influencing a behavioral confounder.
So pleiotropy is basically the hidden puppet master sneaking back into your genetic model.
That's a perfect way to put it. If the gene you're using as a proxy for LDL also happens to make people more likely to smoke, then your MR result is biased. And we have to use sophisticated analytic methods to try and detect and adjust for this pleiotropy.
So what's the ultimate value of this complex genetic method?
It's invaluable for confirming causal relationships we already suspect, for identifying new ones, but also for saving vast amounts of resources by redirecting research interest. If a big observational study suggests a risk factor is causal, but a well-done MR study provides no support for that link, researchers can ethically and confidently move on, preventing wasted effort and money chasing non-causal targets.
All right, let's wrap up our epidemiology toolkit. Quick check. You're designing a study to find out if taking drug X causes a rare side effect Z. You decide to find 100 people with side effect Z and 100 people without it, and then ask them both about their past use of drug X. What type of study design are you using, and what is its main limitation? If you need a refresher on the pros and cons of working backward, just rewind to the study design section.
And the key takeaway from this section. While the randomized controlled trial is the pinnacle of evidence, epidemiology is the art of balancing chance, bias, and confounding. And techniques like Mendelian randomization are transforming the field by using the natural randomness of genetic inheritance to strengthen our ability to infer causality, especially for lifelong, modifiable risk factors.
We've talked about measuring disease and proving causality. All of this relies on just massive amounts of data. So how do we turn the fire hose of raw, messy information that our health systems generate into useful, unbiased health knowledge for the whole population?
Well, we start with the traditional systems. Vital registration, the legal requirement to register all births and deaths, is the absolute backbone of this. The cause of death is recorded using the international standard, the ICD-10 codes.
But just relying on death certificates for global comparison must be incredibly difficult. What are the main challenges?
There are 5 major systemic hurdles. You need standardized terminologies like ICD. You need assurance that those terms mean the same thing everywhere. You need consistent access to diagnostics. You need standard protocols for how to assign the codes. And you need robust quality control.
And these systems often miss a lot of what's happening outside of the hospital.
They do. They often lack detailed data on community-based care or the process of healthcare. And that's why there's such intense interest now in using modern data sources, electronic health records, radiology systems, drug dispensing databases.
But these new systems bring their own problems.
They generate massive amounts of data, but they introduce a new problem. The data is messy. It's less structured, and its completeness and accuracy depend entirely on how individual clinicians actually use the systems on the ground. If a doctor doesn't meticulously record a diagnosis with the right code, that data is basically lost for population health purposes.
And this challenge taming the messy data fire hose, this is where the discipline of health informatics comes in.
Exactly. And informatics addresses this with 2 strategies, standardization and automation. For standardization, they develop comprehensive classification systems. The most important one right now is SNOMED-CT. This is a standardized, multilingual vocabulary designed specifically for electronic health records. It provides consistent terms for everything from symptoms and findings to procedures.
Why does SNOMED-CT matter to you, the future doctor in the clinic?
It matters because it makes your documentation scalable. When you use SNOMED-CT terms, you ensure that the clinical information you put in about one patient is instantly usable for secondary purposes, for research, for auditing quality of care, for monitoring population health trends, and critically, for training AI models. Without this standardization, every data set is just an isolated island.
And on the automation side, what modern techniques are being used?
They're using statistical methods like natural language processing, or NLP, to pull useful, structured information out of free text reports, like automatically identifying a diagnosis from radiologist notes. And they're also applying advanced machine learning algorithms to spot patterns in those large, complex, messy data sets where a human could never find them. Hashtag tag 5.2 management of epidemics.
Okay, let's turn now to the really urgent side of population health, the unexpected spike in cases, the outbreaks and epidemics. What actually defines these events?
Well, the World Health Organization defines an epidemic as when cases of an illness are clearly in excess of normal expectancy in a community. A small-scale, geographically confined epidemic is usually called an outbreak.
And a pandemic.
When a novel agent spreads beyond international borders, the scale becomes a pandemic, like SARS-CoV-2.
What usually causes an epidemic to kick off?
Typically, they come from 2 sources. First, a breakdown of preventative measures. A food safety breach leads to an E. coli outbreak. Failure to maintain a building's cooling tower causes Legionella. A drop in vaccination coverage leads to a resurgence of measles.
And the second source?
The emergence of novel infectious agents that humanity hasn't seen before, like MERS or the original SARS.
So how does the public health system achieve early detection?
It relies on continuous surveillance. Public health agencies monitor cases through things like statutory notifications, where doctors are legally required to report certain diseases, and through automated health information systems. A crucial, often human-driven step is distinguishing a true epidemic signal from just normal, sporadic cases.
And once a signal is confirmed, the incident management team is deployed. What's their first step?
Their very first step is to establish a clear, formal case definition defining confirmed, probable, and possible cases to make sure everyone is counting the same thing. Then they move rapidly to contact tracing and environmental testing to try and confirm the source.
And once the source is identified, they implement control measures.
Right, and these often come with legal powers. Isolation of infected people, temporary closure of a contaminated restaurant or food plant, or large-scale product recalls. The whole process hinges on speed and accurate tracing.
How do they track if their control measures are actually working in real time?
They use the epidemic curve.
Yeah.
This curve is the fingerprint of the outbreak. It's a simple chart of new cases over time, but the shape of the curve is incredibly informative.
What can it tell you?
A sharp, single peak suggests a single source. like a contaminated meal at a wedding that was successfully eliminated. A sustained, longer curve suggests person-to-person spread, or a continuous source that hasn't been controlled yet.
So the curve is crucial for monitoring and for estimating key statistics.
Yes, it helps estimate the incubation period and the basic reproduction number, the R0. By watching the curve, the team can project future scenarios and use other methods, like a rapid case control study, if the source is still proving elusive.
And finally, as we saw with COVID-19, pandemic management operates on a totally different scale than a local outbreak.
It does. Pandemics from novel agents are rare, which means agencies lack direct experience, and they pose risks to society-wide infrastructure transport, food supply, not just the health service. This rarity and systemic threat is why countries need to have pandemic plans and run regular high-level tabletop simulations to make sure everyone is prepared to coordinate when the inevitable happens.
Okay, a final challenge for you. What is the primary function of SMOMED CT, and why is it absolutely necessary for modern health informatics and the future use of clinical data? If you can't link UnknoMed CT back to that idea of a messy electronic health record, just rewind and listen again to the data section.
And the final key takeaway to integrate all of this: your role as a future clinician will go far beyond just treating the individual. By understanding population metrics like dailies, by recognizing that layered hierarchy of determinants from molecules all the way up to the climate, and by mastering the epidemiological tools used to prove causality and manage outbreaks, you will be equipped to advocate for and participate in effective public health action to ensure your patient isn't fighting against policy, but is actually supported by it.
This deep dive really shows that successful medicine in the 21st century requires us to stop thinking of disease as just a molecular or cellular failure. It's an emergence. It's a culmination of complex interactions with this layered world all around us. Understanding these population health concepts provides essential context for every single disease you will ever study.
And that context leads directly to a final provocative thought. We've seen that sustained economic growth in high-income countries hasn't solved the litany of socioeconomic problems: rising crime, persistent mental health issues, crippling inequality. So, given the profound health impacts of high BMI, of pollution and climate change, should future medical practice focus more aggressively on systemic advocacy, on redesigning the obesogenic and unsustainable environments, rather than simply continuing to invest overwhelmingly in treating the inevitable consequences that they produce?
That is the ultimate ethical and strategic dilemma for the next generation of doctors. Thank you for joining us on the deep dive. Remember to use this knowledge as your foundation and seek out the detailed sources mentioned, the GBD reports, the Stroke Messer guidelines for deeper reading. Until next time.